Good evening and welcome everyone to the first meeting of the Adults in the Health Scrutiny Review Board for 2023. We have a packed agenda this evening. I'd like to welcome Councillor Khan to this board. I know you sat on it before, Councillor Khan, but you're new this year. And welcome Councillor Patterson. And welcome back, Councillor Froggatt and Councillor Lonsdale. So I think we have apologies from...
Councillor Alison Holmes, thank you.
Thank you. We do have a late item, which is the topic review that we did on care homes during the early part of the pandemic. We did actually agree the recommendations from that at our last meeting, so this is just the narrative that goes with it. So we're going to look at that in a moment. Any declarations of interest? No. And we have two sets of minutes to note and agree to. The ones from what are the dates of both of our last meetings? The minutes need approving. So it's the 21st of March and the 19th of April. Does everybody accept those minutes?
Move as read.
Yep. Thank you very much. Okay. So I'm going to slightly adjust the agenda too, because Dr. Dewis has to leave at a certain time. So I'm going to bring forward some of her items up the agenda, just in case we're running late, but hopefully we won't be. So obviously, the people who are already on the board are aware that we carried out a topic review into the situation in Derby with respect to care homes called Protecting Care Home Residents and Staff. As I said, we agreed the recommendations for this at our last meeting. We now have the full report in front of us, and I think I'm inclined to read to you my forward to try and, because in the forward I tried to sum up some of the key points that we found, some of the difficulties we had in actually carrying out the review and some of the positive things, and the experience overall. So I think it would be easier for me, if you bear with me, if I just read it rather than try and report from it. So here we go. Care homes house the elderly and the vulnerable in our society. They are homes that people turn to often when they're most in need after a lifetime of working, caring and living in families, couples or as individuals. For many, the care home will be where they spend their twilight years and probably their final years. Care home staff deal daily with the realities of later years' life, something we all face later, if not sooner. It is clear that when the coronavirus pandemic in the UK was finally recognised by the government in March 2020, care homes were something of a twilight zone for the pandemic response and policy. In certain respects, care homes are anomalous in relation to the spectrum of the idea of home held by much of the population. They are a form of collective living, yet people enter them qua individuals, often with high levels of dependency on institutionalised care by others, albeit in what is a home and it's not an institution. The blanket instructions to stay home and protect the NHS thus rather inevitably miss the mark in terms of the specificities of care home living. Yet, given that the government were faced with a global pandemic already indicating elsewhere that it was posing a grave risk to the elderly and vulnerable, the scant attention paid to the particular situation of care homes in the early stages of the pandemic is a matter of national shame. Many reports have documented the consequences of this neglect. Releasing their latest findings, the Care Quality Commission have stated in March 2021, the impact of the pandemic on people who draw on and work in adult social care services has been devastating, and despite the best efforts of staff, COVID-19 has contributed to a significant increase in the number of deaths in nursing and residential care settings. On the 27th of April 2022, the High Court ruled that the government's policy of discharging patients into care homes in March and April of 2020 was unlawful. The court was told that around 20,000 residents of care homes in England died of COVID-19 during the first wave of the pandemic, and that hospital discharge policies failed to take into account risks to the care home residents from non-symptomatic transmission of the virus, a policy described as irrational by Lord Justice Bean. I have a quote there from Lord Justice Bean, but I'll leave that. The topic review this topic review had the aim of looking into protections for care home staff and residents in the early stage of the pandemic with regard to the responses of services and authorities in Derby. Much of that was dictated nationally, and our inquiries focused on the local response to the national guidance and the extent to which local decisions or actions were beneficial or could benefit from improvement in any future health emergency. For the most part, problems were reported across the country during the early part of the pandemic, problems that were reported, such as inadequate access to PPE in care homes, or which have become clearer subsequently, problems with hospital discharge policy, a lack of testing, the isolation of residents from their families, all existed in Derby to a greater or lesser extent. Many of these issues were identified early on by the local agencies, whose close collaboration ensured that some of the worst outcomes seem to have been avoided in our city, although COVID still led to an increase in care home deaths and left many staff unprotected, whilst care home residents were isolated and separated from their families, who often had no contact with their relative. The focus on protecting the NHS was certainly a factor that sidelined care homes, leading to hurried discharge from hospital, a shortage of PPE for care home staff, and some uncertain medical care, especially from GP services. Yet NHS services were not necessarily deployed to the best effect. The Derby and Burton Hospital Trust responded to pandemic modelling in early March 2020, which predicted that their services would be rapidly and severely overwhelmed. This led to a prioritising of COVID patients over all other forms of medical need, in spite of the fact that the modelling soon became inaccurate, owing to the government's subsequent announcement of the first lockdown a few weeks later, which actually prevented the level of transmission that had been anticipated. Opportunities for a localised response relative to local conditions were limited, and mechanisms for communication back up to Whitehall appeared to have been equally limited. None of our inquiry respondents had felt empowered to anticipate dealing with the pandemic very far in advance of the governmental directions to do so in March 2020, despite international indications in late 2019 that a particularly virulent virus was spreading rapidly in other countries. It was clear from all our inquiries, nevertheless, that all the medical and social care staff and managers were making the utmost effort to respond to what was, as became apparent in the spring of 2020, something previously unknown to them. The local resilience forum did show resilience, and collaborative working between the NHS, public health, social care and the voluntary sector achieved much and gave evidence of a way to make things better in the future. It is a disappointment for the board that we were unable to talk with care home residents and staff for the purposes of our review, despite our best efforts to do so. Some important experiences of the pandemic thus remain unrepresented here. However, all those we interviewed who work with care staff or who represent carers are very much of the view that care staff are underpaid and undervalued, and their status must improve if care homes' conditions are to be maintained and improved in the future. More work on the provision of care in a residential setting and indeed in a domiciliary setting would be desirable to maintain some focus on what is, in some respects, a problem for our time. I'd like to thank everybody who agreed to take part in this topic review, to discuss their role, their actions and experience, and to offer suggestions for improvements for the future practice. I also thank my fellow board councillors for their input and assistance in the review, and our scrutiny officer, Lindsay Stevens, for her work on the review. On occasion, reflecting on and analysing what was, for most of the population, a very trying and sometimes tragic time, proved to be quite a moving experience for us. We all paid tribute to the health and care staff who were on the front line during the pandemic and who did their best under challenging circumstances. And we remember all of those who died of COVID-19, a pandemic which is not yet history. Okay, thank you. So that's my forward. There are now lots of notes justifying our recommendations. I'm not going to go through those again because we looked at those in April. Do we have any comments on this? On the report as a whole? No. Councillor Patterson, you weren't part of the review. I appreciate that, and thank you for taking the tolerance of listening to me read that out. But it was quite an experience for us all, really. Any comments? Good. Are we happy to note and accept that report then? Thank you very much. Okay, let's move on. Oh, right. Okay, I'm sorry, I've missed out. Recommend that the report to Cabinet, recommend the report to Cabinet for their consideration and to determine any other accountable bodies to which the report may need to be referred. Are we all happy with that recommendation? Thank you very much. Okay, thank you very much for that. Moving on then, I'm going to, Dr. Dewis has to leave at a certain time, so I'm going to move item 9 up to now so she can give us her latest COVID update. Thank you.
Thank you, and it's a very brief one today. So as we've talked about before, the data that we have locally now for cases in Derby, we rely on the national survey data, the ONS survey data. So that always runs slightly out of date because of the nature of the survey. So the data we have is for the week ending the 24th of June, and in that week in England and also in Derby, it was around 1 in 30 people who were positive for COVID, which gives us a level of around 3%. And what we have seen over the past few weeks, I think since that survey data, is we've seen starting to see an increase in hospital admissions. We're starting to see an increase in cases in care homes, and I'm sure everyone will reflect also to start to know people who have COVID again, which is you sort of know from our friends and family. So you can also feel that is indicating that the levels are increasing in the population. The particular variant that is circulating at the moment is Omicron, but it's Omicron BA4 and BA5. So it's a slightly different version than was circulating at Christmas, which was BA1, and at Easter, which was BA2. And there are some implications with that, both from the time that's passed since the previous waves and the fact that immunity will start to wane over that time, but also that BA4 and BA5 are slightly different. So the fact that we've had Omicron before won't necessarily protect us from having Omicron again. As with previously, we can see that the vaccination is protecting really well against serious illness, which remains to be really good news. And from the vaccination perspective, that's continuing to be rolled out. We've just got the start now of the second doses for the 5 to 11-year-olds, and also a call through the NHS for everyone who's not had their spring booster. So those individuals who are either care home residents, the over 75s, or those with really significant health problems that would leave them really vulnerable, all of those people who were eligible for the spring booster, just a call for anyone who's not had the vaccine to come forward as we're seeing the cases rise. I think the only other thing to mention is that it's difficult to have a crystal ball, but we anticipate as we move towards the autumn and into winter that we will see a further wave, that this won't be the last that we see of COVID. And just some concerns, again, as there have been in previous years, about what the impact of flu might have this winter as well. Australia has been seeing quite an increased level of flu circulating, and we do look to Australia to see what we might anticipate coming to our shores in the autumn. So I'm very happy to have any questions on that.
Thank you. I think Councillor Froggatt just took it there. His hand up first. And
Hi. Just to ask the question, the ONS, do they take their findings from track and trace? Do they still use the track and trace? Because a lot of people don't use track and trace anymore.
No, it's the ONS survey has been running all the way through the pandemic, and it's very much a research-based study, so it's based on sampling the population. So it's a very robust method that they use to get those results. So I think we can be very positive about the results that they get and trust them. Yeah.
Councillor Khan.
Yeah, the new variant, have we got a plan in place that if that increases, so how are we going to handle that way forward? So have we got something already planned that depending in winter, how fast it grows?
I think that's a really good question, and I think the challenge we have is that our testing program that we now have means that we won't be detecting new variants as quickly as we did before. So when we saw Omicron arriving in December, we knew very quickly it was here, and we watched its growth rate really, really closely. Whereas now, the level of PCR testing, which is what we need to find out, is quite low. So there's some hospital admissions that are having PCR testing, and there's also some of that routine testing and outbreak testing happening in care homes as well. But other than that, and then this ONS survey data, which is sort of a week or so behind, there's very limited information we have around any variants circulating. So I think that's the first challenge that we have, is that early warning that we had before won't be there. And we've had lots of conversations and discussions around being able to step up some of the things that we had in place before. But a lot of what was in place before was additional capacity, additional funding in place, and also the national testing programme as well that was in place. So there's a limited amount that we can do locally, and we can keep a close eye on the rates. We work really closely with the NHS and with the care homes in controlling those outbreaks. And we're in really good communication with the schools as far as any early warning we might get from the schools' perspective. But we will need to see what the UK Health Security Agency's response is if we get a new variant and we get an increase from something that looks very different. What we're seeing at the minute seems to be behaving very similarly to Omicron, and so we sort of know what to expect with it. If there's something that comes that behaves quite differently, then we will need a national response to support us in understanding what to do.
Thank you. Councillor Lonsdale.
Thank you. 2 questions, actually. Should we be asking the government to put in place the national testing thing again? Should we be trying to get is this an early warning that we need to be getting the testing back into place? And also, are there any other variants out there in other countries, say, that we're spotting that we might look at and be concerned about?
So on the first one, so what we're currently seeing, the BA4 and the BA5, we've seen in other countries, and we've seen quite a predictable rise and fall over sort of 4 to 6 weeks happening in other countries. So I think there's a relatively good understanding of what we anticipate seeing. We anticipate seeing an increase, which will no doubt impact on those individuals in hospital who've got the infection, whether they're in hospital for that or whether they happen to be found. There may be an impact on staffing capacity just because of illness, but we're not anticipating seeing anything dramatically different to what we've seen, say, at Easter with this current wave. I think the challenge is what we might see in the future, and there isn't, as you're saying, is there something internationally that you're currently watching? There's not anything that I'm aware of that we're currently concerned about. I think the issue is COVID hasn't finished. It hasn't settled. So there's plenty of more variation that could potentially come, but there's a huge amount of uncertainty about what time frame we might be thinking about, or what that might look like, and indeed which way it may drift. So whether it moves towards being a less severe illness or a more severe illness, all of that is really uncertain. And I think that's the huge challenge. There's a little bit of waiting and seeing, but also ensuring that we know what we can do within the resources we've got at the moment as well.
Thank you. Any further questions on that? Councillor Khan.
One final question. So public health, how are we sort of working at a local level with like GP services, primary care and all that? So are public health working very closely with them?
So we work very closely with the NHS in general. So we're part of the Integrated Care Partnership and the system, and work really closely. And we have linkages both with the hospital trusts and with the primary care networks as well, which the GPs are formed into. So it depends what area of work it is, but there's certainly areas of work where we do work closely.
Thank you. Yeah, I mean, it's obviously an area of concern and needs monitoring. We were going to discontinue these COVID updates, Robin, but I'm not sure on the basis of that report that it is a good idea to. I think we should, and it's just keep it as a standing item on the agenda, if that's all right. So thank you for that update this evening. No further questions on that? No, thank you. Okay, so now we are going to move on to our second report, I guess. Provision for people with chronic conditions such as ME, chronic fatigue syndrome. And this is presented by Julie Pickering, Zhang Lin, and Grace Pern from the University Hospitals of Derby and Burton NHS Trust. So who's going to begin? I don't know.
That's me.
Okay, thank you.
Thank you. So my name's Julie Pickering. I'm the team leader for the Chronic Fatigue Syndrome ME service in Derby, and I'm a physio by background. And with me today, we've got Grace Pern, who's the Director for Allied Health Professionals and Clinical Scientists, and Dr. Jarlin, who is one of our consultants in rehabilitation medicine. Next slide, please. So I was asked to put together a presentation on the following items. So first of all, to discuss what is ME-CFS, to discuss the number of people suffering, to describe the current situation with service provision for ME-CFS in Derby, to look at the nature of treatment provided, the outcomes of treatment, and also to have a look at the NICE guidance and the all-party parliamentary group report. Next slide, please. So ME-CFS is a complex, multi-system, chronic medical condition. It has a considerable personal, social and economic consequences, significant impact on the person's quality of life, including psychological, emotional and social well-being. So the main symptoms of ME-CFS that somebody will describe will be debilitating fatigue that's worse with activity. It's not caused by doing too much, and it's not significantly alleviated by rest. It's accompanied by post-exertional malaise, so when the individual does more, they tend to feel worse the next day or the day after, and the worsening of symptoms can last for a number of days or weeks or even months. The person will describe unrefreshing sleep and also cognitive difficulties, so problems with memory and concentration, processing, often using the terminology brain fog. And there are multiple other symptoms as well that people will present with, and no two people are alike. So ME-CFS falls into different categories of severity. We can have people who are fairly mildly affected and self-caring in work and education, through to people who are severe or very severely affected. They are fully dependent, maybe bedbound and needing help with all aspects of care. And it's estimated that during their time with ME-CFS, around 25% of people with ME will fall into the severe or very severe category. The All-Party Parliamentary Group report 2022 identified that people with ME require targeted service provision, including health and social care, and research by 2020 Health showed that when lost taxes, welfare benefits, health and social care costs were considered, the total cost to the UK economy of ME in 2014 and 15 was at least 3.3 billion. Next slide, please. ME/CFS is classified as a neurological condition by the World Health Organization. And looking at the number of people affected, NICE in 2021, looking at recent data from the UK Biobank, suggests that there are around 250,000 people in England and Wales with ME/CFS. There are around 2.4 times as many women affected as men, and ME/CFS can affect people of all ages, children and adults alike. Next slide, please. So service provision in Derby. We are based at Florence Nightingale Community Hospital. We sit in a department where we work alongside our colleagues, working with other conditions, with people who are attending with neurological conditions in an outpatient setting. Our service was established in 2004 for adults aged 16 and over. And that was the result at that time of a report to the Chief Medical Officer who provided a service investment programme which set up, I believe, 36 adult teams at that time with 13 regional network coordinating centres and also 11 services for children. At that time, there was also the development of BACME, which is the British Association for the Clinicians with ME/CFS. We've been fortunate that our service has continued since its establishment in 2004 and has gone from strength to strength, and extremely fortunate to retain our clinical network. So the East Midlands Clinical Network Coordinator, who is also the BACME Deputy Chair and Treasurer, is also based at Florence Nightingale Community Hospital. So we receive referrals from any area, but the vast majority are Derby and Derbyshire. We haven't got any strict geographical boundaries, but we would always encourage GPs or referrers to refer to nearer services where those are available. And there are the nearest services, other than the service at Florence Nightingale, are in Nottingham, Lincoln, I believe there is still a service in Leicester, and then further north there is a service in Sheffield. So along with providing assessment and treatment for people with ME/CFS, we also provide advice and guidance for GPs. We provide training for other disciplines, and of course we ensure that our own team are kept up to date with evidence base, and that we provide training and support, supervision for all members of staff within the team. Next slide, please. So the team, we have a multidisciplinary team. We've got 6 therapists, all at band 7, equivalent to 3.5 whole time. And they're a mix of occupational therapists, physiotherapists, and we also have a cognitive behavioural therapist within the team. And we've also got our admin support. And of course, we've got our consultants in rehabilitation medicine, of which Dr. Lynn is one. The staff, as I say, are all band 7. This gives them a broad background of experience, which is required for this condition because of the complexity. But the staff also have considerable personal skills, so they're able to build a good rapport with people coming through the service. Next slide, please. Early on in the pandemic, we expected an influx of referrals. I don't think we realised quite how big an influx, but we put together a business case due to long COVID, where we requested additional staffing to enable us to manage referrals coming through for long COVID as well as ME/CFS. And we were able to recruit an additional 2 occupational therapy staff equaling 1.2 whole-time equivalent, and additional admin support. Thanks, okay. So those staff have been hugely beneficial in helping us to manage referrals coming through with long COVID. So we have provided therapy to people referred via the long COVID assessment service, and we've been able to liaise and guide other staff working with patients with long COVID that are experiencing fatigue. We have now happily also recruited a member of staff specifically to work in the new long COVID rehabilitation hub, so separately to the CFS-ME service, and that will help in managing those referrals. Next slide, please. So just looking at referral numbers that we've accepted over the years, in 2018 to 19 we had 256, 2019 to 20, 236, 2020 to 21 we had 117, and we were just starting to see the first long COVID referrals coming through at the end of March in 2021. And then in 2021 to 22 you can see that we've had 210 referrals for ME/CFS and a big increase in the long COVID referrals. I want to just mention the drop in referrals for ME/CFS in 2020. The referral rate significantly dropped during COVID pandemic when people just were not going to see their GP. Since putting these numbers together, I've looked at what's coming through, and the long COVID referrals that we're receiving from the long COVID assessment service are now minimal, and most of those will be going to the post-COVID rehabilitation hub. Next slide, please. So in terms of what we do with the people that come through to our service, we do follow the NICE guidance, the new NICE guidance for ME/CFS. As people are referred through, they will receive an appointment with a therapist where they have a holistic therapy assessment, and then treatment considers of really advice, providing self-management strategies to help the person to self-manage their condition, aiming to reduce the severity of symptoms, improve symptom management, and generally to improve quality of life. And this is including support with engagement in social, leisure, education and employment. We provide reports to support employment, education and welfare applications. And we don't have a set number of sessions for each individual. It really does depend on the individual need. Just as all the treatment is completely person-centred, so is the number of sessions. We have to be clear with people coming through that there is no cure for ME/CFS, and that's not what we're aiming to do. It would be wonderful if we could cure this condition, but we give the very best that we can to help people to get it under control rather than the condition controlling their lives. Next slide, please. So I mentioned that we also have our consultants in rehabilitation medicine. So some of the patients coming through to the service will go on to see one of our consultants, and that might be for a number of different reasons. So some people, when they're referred through, the GP is not 100% certain of the diagnosis of ME/CFS. They might be suspicious of it, but they're not absolutely sure. Or there may be something in the referral that makes the therapist think, well, actually, I would prefer a doctor to see that patient because they've got this other medical condition that actually needs somebody more skilled and qualified to make a decision on diagnosis. So it may be that the patient goes through to a consultant for initial diagnosis. Often people require further investigations. The GPs do have to do a number of set blood tests before patients are referred to us to exclude other possible causes of fatigue. But further down the line, when we've asked our questions, it may be that there are more investigations required, and our consultants can arrange for those. The consultants can also advise on symptom management, for example, treating pain, disturbed sleep, and can advise GP on prescriptions. Sometimes the therapist is working with a patient and isn't quite sure about something that the patient has said, which has a medical requirement, and again will refer on to the doctors. Sometimes it's simply that the person that we're working with themselves, they're not sure about whether they've got ME/CFS, or they have a symptom that they're not particularly happy with and don't feel has been adequately investigated. So if somebody asks to see one of the consultants, we will honour that and arrange that appointment for them. Sometimes people need to be referred on to other services. So it might be that they require referral onto a sleep clinic, for example, or to cardiology, or any other service depending on the symptoms that the patient presents with, and the consultants can arrange those referrals on. And of course, the consultants can also provide medical reports where a medical opinion is required. So for example, that might be something such as for ill health retirement for patients that are already under the care of our service. That might be something that the consultants would support with. Next slide, please. Treatment mediums. So prior to the pandemic, everything was largely face-to-face with a few telephone appointments. But the pandemic brought about the access to telemedicine. So we generally, where possible, try to see people face-to-face for an initial appointment. If that's not possible, if they can't make it into the hospital, that's okay. And follow-up appointments will generally be face-to-face or over video or over the phone, depending on patient preference. And particularly for those people living a long distance from Derby, that makes the service a lot more accessible for them, and they don't have to deal with the fatigue of getting ready, travelling, dealing with a hospital environment. We have for many years run a group, a face-to-face group for people with ME/CFS, which has been very well attended and very well liked with very good feedback. And of course the benefits of that is the peer support that people are able to offer to one another. And hopefully in the near future we'll be able to get that group up and running again. The pandemic again allowed us to operate a virtual group. This has so far only been run for long COVID, but there is no reason why we shouldn't be able to run this in the future, also for ME/CFS. For the severely or very severely affected, we can offer home visits. Obviously, we're limited with geography. It would be within our sort of local area. And the team is a small team, so I guess we have limited capacity, but home visits are a possibility. Next slide, please. So outcome measures. I think outcome measures are gathered in two different ways. One is objective, so we have some scores that we use, but the second is subjective, so it's what the patients tell us about the service and what they think about what we're doing. So the objective measures that we use, we give the patients a set of questionnaires to fill in to bring with them to their first appointment. So they receive these in the post prior to attending. And then after that, 12 months after that set of initial questionnaires, we'll ask them to repeat the same scores again. So some of these people might still be with the service and some may have been discharged. Not every patient is good at returning the questionnaires. So we get some back, but we don't get every set that we send out for that 12-month period. There are a large number of questionnaires, and I do appreciate that patients are fatigued, but they don't have to complete them all in one go. And because the condition is so complex, it's really important that we gather data across a broad spectrum of things that the patient might be wanting to describe. So we have an Epworth sleepiness score, which looks at daytime sleepiness. We have a VAS, which is a visual analog scale. That's a pain scale. We have an anxiety and depression scale called a Core 34. An SF36, which is a measure of the individual's ability to perform certain tasks regardless of fatigue. We have a self-efficacy score, patient's level of confidence in performing tasks or in controlling fatigue. And we have a shoulder fatigue scale, which measures both physical and cognitive fatigue. Next slide, please. So I've brought the data from the 20 to 21 period. The blue shows the scores, the average scores at initial assessment, and the red shows the average score at the 12-month follow-up. So I will say that all of those scores show an improvement. So there's a drop in fatigue for both cognitive and physical. The SF36, which is a measure of physical function, an increase in score actually shows an improvement. The VAS, the pain scale, has dropped. The Epworth sleepiness score has dropped. The self-efficacy, which is also an increase, also actually again is an improvement, showing that the individual feels more confident in managing fatigue. And the core, the anxiety and depression scale, has also reduced. Next slide, please. So I mentioned that those are our objective measures, but the subjective measures, what the patient tells us, is hugely valuable. We have a clinical performance indicator. It's basically a statement that we try to adhere to and measure ourselves against, which says that a minimum of 80% of respondents to the service evaluation questionnaire that we send out, this is separate to the outcome measures, will report being more confident in self-managing their condition. And over the past 3 years, that's run at 95%, 94% and 100% of respondents. We also use the patient experience cards, the feedback forms, and we get hugely positive feedback that people have, the praise that people give to our service, and I know for a fact that we are recommended to friends and family as a result of the care that we provide. The things that stand out are people saying that we've spent time with them, that we've believed them, and that they felt listened to, which I think speaks volumes. Next slide, please. So the response to the new NICE guidance, which came out at the end, I think, of 2021, we've recently, just in the last month, undergone a baseline assessment tool to look at the recommendations, all of the points in the NICE guidance, and we've measured ourselves, we've checked what we're doing as a service, and we feel that we're working well within these guidelines. There are probably some areas where we need to just tighten up a little, and we'll continue to monitor ourselves against the guidelines and ensure best practice, and we'll always use the NICE guidance as our benchmark. I'm sure people have heard, or may not have heard, about graded exercise and cognitive behavioural therapy. And so just to reassure everybody that as a service we know that graded exercise therapy can cause potential harm. There are people who do wish to increase activity or exercise levels, but that's very much up to the individual, and if that's the case, it's led by the person. We would do it very safely with careful timing, regular reviews and adjustments as required. We do have a CBT therapist. We don't offer CBT as a cure, but a number of people that come through the service, they've had this condition. It's had a significant impact not just on their physical health but also on their mental health, and the CBT is hugely valuable in offering support for those people whose mental health has suffered as a result of the ME. Next slide, please. So finally, this is the last slide. The All-Party Parliamentary Group made some recommendations following the publication of NICE. And the 5 recommendations were that there should be greater spending on biomedical research. There is research ongoing, but there has, over the years, been very poor funding for this compared to other long-term conditions. It recommends that there should be improved diagnosis, symptom management and access to services. I would comment on that sometimes, often patients come through to the service that have had symptoms for years and the diagnosis has been slow. Diagnosis can actually be made at 3 months following onset of symptoms, so earlier diagnosis and referral would be hugely beneficial. It identifies the improvement in services required for children and young people. I forgot to mention at the start that whilst we take adults over the age of 16 in our service, children under the age of 16 are seen by paediatricians and the therapy team over at the Children's Hospital. There's also a recommendation that people are able to access welfare and that their health insurance benefits shouldn't be measured against their treatment for ME/CFS. People that come through the service have huge difficulties accessing benefits, often PIP, which they have to apply for. They may well be declined at the initial attempt. They go to appeal, it may be declined again. It goes to tribunal, and it may be successful at that point, but it's a hugely laborious and fatiguing process for the patient. And the questions are not easy for somebody to answer who's got a condition where the symptoms fluctuate, and it's not so much what you can do at the time, but also the impact on your condition having performed a particular task. And the final recommendation was that the research that's ongoing for long COVID should join up with the ME community, because there are so many similarities between the two conditions, and both can support one another with the research that's out there. Thank you.
Okay, thank you very much. Any questions? I think, was it Councillor Froggatt got in there first as well, or was it Councillor Lonsdale? Okay.
I do not mind. Well, thank you very much. That was very interesting and actually quite reassuring. I am actually an ME sufferer myself, so and I have several people who have ME in my ward, so it's very reassuring what you've just said. One of the questions I want to ask, and there's a couple, is what are the waiting times for a referral and to see the service initially? So GP goes, right, this person might have ME, and also from your service, if somebody has asked you to go to a consultant, what sort of waiting times are they expecting? Because that is quite tiring in itself.
So the waiting time for an initial therapy assessment at the moment is not where we would like it to be. It's currently sitting at around 6 months. We would like there to be no waiting list whatsoever. It's what we're always aiming for. We have had it that good in the past, but we did take a hit with the COVID referrals, and although we've got through those and there are very few coming through now, that did impact on the service. So yes, we would like to see that improve. The referral onto a consultant, that will be as soon as there is an available slot. So if somebody has been into the service and they have seen a therapist and the therapist thinks that the patient needs to see a consultant, that slot would be prioritised on the consultant's schedule. So it's usually, I would say, within around a month. It might be slightly longer, but it would be prioritised because there's no point waiting twice.
Okay, what sort of training is there for GP? So like, with getting my ME, which is nothing to do with Derby, but we're getting my ME diagnosed. It took me years for a GP to actually take me seriously. So do we have any specific training for our GPs around Derby?
So we've offered training in the past and there has been some uptake in that. I don't think we have anything currently planned, but I'm sure that's something that we would be more than happy to arrange in the future. And that would probably be something that our network coordinator would work on. She would look to be able to arrange some training for GPs.
Thank you. Councillor Froggatt.
So, apologies for me back. Thank you for the report. It was very enlightening, and I'm afraid Councillor Lonsdale pinched my question about the referrals. So, adios.
I do have a few points actually, if I may. Thank you for the report, and it is an honest report, I think, which is kind of refreshing because you are actually acknowledging that that CFS and ME are not they're not going to be cured by CBT or OT or physiotherapy. So I thank you for that honesty, and clearly that can help people, but it does remain a matter of concern that this is a problem, a chronic condition that is not being treated at all, in effect, for the condition that it is. And so I personally welcome the government's intention to spend more on biomedical research, because I do think this is a molecular condition that needs biochemical analysis. But I do actually know that there are private clinics already doing that, and which then treat conditions with a series of nutritional and supplement treatment, which can be very effective. So again, it doesn't guarantee a cure, but it does often see very, very good outcomes. I mean, many conditions are not curable as such, are they? But people do actually largely overcome them. But it's still in the system to potentially return. So I just wondered if there's any acknowledgement of the validity of those clinics in Derby. I appreciate they are private clinics, but from my own experience, I think it would be very valuable if all CFS and ME sufferers could actually access some of that help too, not for a moment devaluing the work that you do, because I think just acknowledging someone's condition for these people is a huge therapeutic intervention and helping people manage a condition. But there are already some treatments out there that also seem to be quite effective. So I wonder if there's any prospects of people accessing that in Derby. Thank you.
Thank you for your question. Yeah, it is a condition which has had a lot of behavior research in the past. Therefore, the concept, in the old concept, is a behavioral problem. And only recent years, or probably 8-10 years, with a lot of biological and medical research, like you just mentioned, really drilled down to lots of dysfunction, such as the cellular level, molecular level, because of energy production, and the immune system, and even genetic influence. You can see a family with probably few members in the family suffer from ME/CFS. So this recent research really started put question mark in terms of what is underlying cause of this condition. Therefore, the whole concept has been changed to neurological medical chronic condition rather than CBT and graded exercise therapy. Therefore, the new guideline in terms of NICE guideline in terms of treatment and management. But unfortunately, I think because some of the patients, they just have ME/CFS with lot of symptoms, and therefore we treat the symptoms itself. In terms of a cure of the condition, at the moment, I think we, the all-party parliament group is calling for more research, and as Julie just mentioned, and also clinical trial in terms of cure of the underlying cause. So as far as I'm aware, there is no clinical trial to say what condition, because the underlying cause is still unclear. So it's very difficult to find a cure for such condition. So when you mention about dietary, all this, I think because there are multiple factors causing fatigue, and also some of them are exacerbating fatigue. For example, if a person has chronic fatigue, we already diagnosed ME, but it turned out this person also suffers from low phosphate and low vitamin D. They might have some hormone disturbances, therefore it's only make the condition worse. So that is aspect we can treat with vitamin D supplement, and some people probably need to adjustment in terms of their dietary regime. So that would be helpful as well. We do get few letters from GP to say whether we can treat fatigue with amantadine. Yes, amantadine is a treatment for fatigue, but only specifically for people with MS with fatigue. So I think at the moment when you mention about private clinic, maybe they treat still symptom, or they still treat element of fatigue. With such a treatment, maybe their fatigue symptom and other symptoms can be alleviated. I hope this answers your question.
Okay, thank you. I suppose just very quickly, because I appreciate we've been on this topic for a while, but I think it doesn't, if with respect, because my question was really, are people in Derby able to access that therapy?
Yeah, sorry. I think probably not far as I know. We haven't referred any people to this sort of private clinic.
Thank you. I appreciate this isn't your decision, and I wasn't actually suggesting that people should be referred to a private clinic. I'm talking about treatments that are quite effective to those who can pay for it and know about it. It can prove very effective, and just that isn't available. So I would like to put a recommendation, if I may. Yeah. So I haven't articulated it yet. So recommends that local NHS services takes evidence from private clinics operating nutritional therapy as a treatment for CFS ME to learn from their experiences and to sorry, Dom, this is just trying to make this up. They take evidence to learn from what the treatments are and to see the evidence of their effectiveness.
Sorry, can I say something? We follow NICE guidelines, basically in the service. So I'm not sure it is recommended in NICE guideline. But we do have nutritional dietitian, in the NHS setting in the community to address dietitian if there is a dietary defect.
Thank you, I appreciate that. What I'm doing is, this recommendation is to the local relevant trust to kind of either do the work themselves or advocate it. So it's not something that you're going to take away personally, or we make recommendations and comments on conditions, services, and then the trusts and the managers reflect on them. So that's my recommendation. I don't know if you got that, Dom. Oh. Well, I was going to deal with this one first, or does it? Is it not?
No, it's
okay. Well, I'll do this one first. So, Dom, can you read out what you got? I'll say it again then. I'll make it up again. I say that Adults and Health Scrutiny Board recommends that local NHS services take evidence from private clinics operating nutritional therapy for CFS and ME patients with regard to the nature and effectiveness of those treatments. Yes, thank you. So is there a seconder for that recommendation? Thank you. Councillor Khan. Can we take a vote on that recommendation? All those in favour? Thank you. It's carried. So what that means is not that we expect you to go out and do that tomorrow. That's a statement of desire, really, to the authorities. Thank you. Councillor Lonsdale.
Okay, separate to that, I think it would be useful if we make a recommendation based on what you said, that we recommend that a training program is set up for GPs for better spotting of ME symptoms and diagnosis, so that people are not having to wait so long to be referred. Also, that more, that we try and bring down the waiting times, but better initial diagnosis from, our initial referrals for suspected MP patients should be a priority. So Yeah.
So the recommendation is to set up a training.
We recommend that we set up another training program for GPs and offer it Derby-wide so that all GPs are able to access that training if they require it.
Thank you. Okay, do you want to add awareness into that?
We recommend that a training and awareness program is set up and offered to local GPs to help early diagnosis and prevent long waiting lists in the future.
Thank you. Do I have a seconder for that recommendation? Sorry, Councillor Froggatt.
Could we also add to that if they do decide to put the recommendation forward from the trust, could we possibly have a response on how many GP services, actually take up the training? You know what I mean?
Yeah. Can we? And we can request that information, can't we, Dom? But do we need to put that as a recommendation? Yeah. So we'd like. Thank you. Yeah. It's a good point. So do we have a seconder for Councillor Lonsdale's motion? Councillor Froggatt. Those in favour? That's carried. Thank you. And we will try and get some further feedback on the services or the effect or non-effect to our recommendations, Councillor Froggatt. Right, thank you ever so much for coming. Thank you for that. It's very interesting and very reassuring on one level, but a lot more work to be done by the biochemists, I think. So Councillor Patterson's just giving his apologies because he needs to leave urgently. So thank you, Councillor Patterson. Right, thank you very much. So now we'll move on to NHS Dentistry. I think we're just going to go and collect the presenters, so we'll just pause for a minute while they enter the room. Okay, thank you very much. Welcome at the back of the room there. Thank you for coming. So just before we move on to the report, which we're looking forward to receive tonight, I'd just like to tell the councillors that, as requested by the board at the last meeting, when the dentistry report was cancelled at the last minute, I did write to NHS England and NHS Improvement to express our extreme dissatisfaction with that scenario, and I have received a short letter in response, so I'll just read the letter before moving on to the report. It said, "Dear Councillor Martin and Lind, thank you for your letter dated the 8th of April. I'm sorry the attendance by the dental team at your April meeting was postponed at such late notice. The team were coming to you to present, unaware of the restrictions on arm's length bodies such as at the NHS during pre-election periods. Specifically, this includes that there is no participation by NHS representatives in debates and events that may be politically controversial, whether at national or local level. and they attach guidance issued for the NHS. Attention was drawn to the meeting by the headlines in the Derby Telegraph the day before the meeting took place. Since the election, we have met with local MPs and Health Watch with regards to dental services in Derby and Derbyshire, and I understand the team are already scheduled to meet you both in July and September. So that's the response we've had. I'm just going to note that for now. I have had discussions with some officers about this, and we are going to address this policy because it has quite significant implications for engaging with NHS services around some times of year. That said, Dr. Dewis, it may become less of a problem because in May next year we move to 4 years elections every 4 years, all-out elections. So there will be fewer elections. It poses less of a problem. But thank you very much. First we have a report. Nhs Dentistry, Early Years Dentistry. From Rosemary Lynch, who is the Senior Commissioning Manager for Primary Care Dental Services East. Thank you.
Hi, can everyone hear me?
I think you'll have to put the microphone up, please, or it's because also it's the session is being cast, so we need to have you speaking into the microphone, please, or else it doesn't broadcast. Thank you.
Okay, can everyone hear me? I've not used one of these before, so I'm just mindful to make sure that everyone can hear me. Lovely. So we have a presentation up on the screen, so thank you very much for the Scrutiny Officer for organising that. First, just to introduce myself. So my name is Rosemary Lynch. I'm the Senior Commissioner Manager for Primary Care Dental across the East Midlands. I would like to also thank the Derby City HOSC as well for the Adult Board for inviting us back to the committee, and as you explained, we were unable to attend at the previous meeting. The paper has been developed by NHS England Commissioning Team Senior Managers and also consultant in Dental Public Health and Public Health colleagues in Derby City Council. Can't seem to see Derby City Council Public Health colleagues who have joined us today in the meeting. Oh, you have. Oh, sorry, I haven't got my glasses on. Hi. Also in attendance, we've also got our Chief Dentist, Adam Morby, and our local dental network chair for Derbyshire, who is Rami Khatib. And we've also got representation from the Derby and Derbyshire Integrated Care Board, who is Clive Newman. And the purpose of so many colleagues is the input and the attendance towards the ICS collaboration, which is the way, obviously, we're going in the future, which is why it's important to have the input in today's meeting. And also it's to ensure we have a engaging HOSC conversation meeting with yourself, so you can answer as many questions as possible. So I'll take the paper as read, but we wanted just to provide you with a summary overview of the pertinent points which has been taken from the submitted paper. So it's important to note that the challenges we see today actually existed prior to the pandemic for NHS Dentistry, so it's not different for Derby City or any other area. We had issues such as access and the growing discontent in the profession around the dental contract as previous. However, each area does have its own challenges, and Derby City's challenges are listed in the slide. It is recognised that Derby City is one of the most deprived areas nationally, and also requires better access for the vulnerable patients, such as the homelessness and people experiencing severe multiple disadvantages. In recognition of these challenges, NHS England, we are additionally currently working with the Derby and Derbyshire Oral Health Steering Group, and that's to look at ways of collaborative working with primary care networks, and that's to strengthen and to support care homes in improving oral health of residents and also access to NHS dental services as a priority agenda. Next slide, please. So this slide provides an overview of the location of NHS dental services within Derby City. It's explained more in detail in the paper, but it also provides a map of where dental practices are. So let me just put my glasses on. So if you see on the map on the right-hand side, you'll see there's some dots, And those dots, you'll see some numbers on them. So those numbers on those dots represent how many dental practices are in that area. The map also gives an overview of the 20% most deprived communities across Derby City, and that's denoted by the purple areas, which you can see there's obviously quite a lot there, and it equates to 37.4% of people within Derby City who live within that 20% most deprived area. Next slide, please. So this slide, taking into account the location of services in the previous slide, this looks at it in slightly more detail in terms of travel. It shows that all dental practices within Derby City are accessible by car within 10 minutes during rush hour. So on the left-hand side where you've got the table, it says car by time and rush hour, and then you've got the 5, 10, 15, 20 and 30 minutes colour coding. So that colour coding is then reflected in the map, which then denotes that it's all the practices within Derby City are accessible by car within the 10 minutes during the rush hour, and that's where the green shaded areas come in. Next slide, please. So this slide looks at public transport to NHS dental services, and the map shows that NHS dental services are accessible within Derby City by public transport within 30 minutes on a typical weekday morning, and the same key is applied here in terms of the 5, 10, 15, 20 and 30, and the colour again reflects onto the map. So I will now hand you over to our Regional Chief Dentist, Adam Morby. He will talk you through the next couple of slides from a clinical perspective. Thank you.
Thank you. Next slide, please. I'm Adam Morby, Regional Chief Dentist for the Midlands, and thank you for this opportunity this evening to come and talk to you. Briefly want to mention water fluoridation, because obviously the Health and Social Care Act came into being earlier this year, and it does offer an opportunity for all adults and people of all ages. Obviously it does reflect the greatest benefits within young children, but as you can see in the Derby City area, there is no water fluoridation at all. So I know it is a contentious issue, water fluoridation, but the profession is strongly behind this, and there are sort of evidence-based research papers that will prove its efficiency and benefits to the population in the area. So it would be an ask of us for councillors to consider raising this with local MPs to make this hopefully a change. But obviously it's been an interesting evening with the resignation of the Health Secretary, so there will be somebody new to raise that with. But next slide, please.
We've been too busy to pick, well, I've been too busy to pick that up, but thank you for that information.
Yeah, and Rishi Sunak has gone as well.
Really?
Yeah.
God. Okay. Blimey. Okay. Well, thank you for that extremely significant information. That is very interesting to us. But back on to the dentist.
Onto the main topic. So obviously, I'm a practicing dentist alongside this role as a regional chief dentist, and first of all, I'd just like to explain with the practices. They are independent practices, and obviously you will have had in your mailbags instances of issues with access and can't be seen on the NHS, but the practitioner can see me privately. This is mainly because practices having to work in the current climate of economy have to decide how much they can work NHS and how much they work privately to actually make their practices viable to sustain them. So that's one of the issues we do face, having to contract with practitioners in that respect. But activity has increased obviously since the pandemic first started. We are now back at expecting 100% activity from dental practices, so this should help influence the ease of accessibility for the community. Through the pandemic, we have seen that practices retained 72% on average people attending practices of the patients that attended those practices within a 2-year period. So we did have some successful scenarios compared to what it could have been. So we are aware of the issues, and one of the opportunities is working with the council and sort of the ICBs and CCGs to look at the joint strategic needs assessments, because this will be one of the first steps in enabling proper understanding the actual needs for the area. And that is an opportunity working with the ICS, because we will get this information right down to place-based and neighbourhood levels, and working with the local dental network chairs such as RAMI, we'll be able to sort of really compound that information to improve the access issues for patients. The other issues that we need actions on excuse me, are families on low incomes, because that is definitely an issue. We've got families that receive benefits, but those patients that earn money just above that threshold of income will definitely need help to support. And it was really just to raise awareness that there is an NHS low income scheme that they can actually apply to. We need to reduce waiting lists as well in secondary care, and work with practices to display the correct details so that patients, when they contact them, they understand where they can actually be seen. So those are some of the issues, and the opportunities that we've listed there will hopefully address some of these issues, especially the workforce issues with golden hello schemes, to try and encourage dentists to work in deprived areas. And then we're going to communicate better from NHS England and have a communication strategy to actually get information out to patients better as well. And we do collaboratively work with the local authorities through the oral health promotion schemes, and we work with the Get It Right First team at a national level to work with hospitals to try and reduce the waiting list that patients are experiencing there with sort of secondary care issues. But overall, as Rose mentioned as well, one of the main things is getting the contract reform, and hopefully in the coming weeks we'll have some news about that to try and hopefully encourage the profession to stay within the NHS and provide more access. Thank you.
I thought there were more slides. Sorry.
Sorry, it was just to give...
I've read the report. It was quite thick, so you've reduced it to some very minimal slides, haven't you? We're just not used to that kind of level. You just caught me out there. Yeah, thank you. I didn't quite hear what you said at the end, and then I was
just to give you the main points and themes of what we're recognising are the issues where we need to work, and then sort of trying to give some solutions.
Thank you. So you finished the presentation then?
Yes, we have. Yes,
yeah, thank you very much. So do we have any questions, Councillor Khan?
You mentioned deprived areas, and some of the dentists practice in deprived areas are still the same. So somehow the community has increased, and in the practice, and the dentists are still the same. So how are you going to address that? Because the communities in certain part of the city where my ward is, the community is largened, and the practice are still the same. Thank you.
Thank you. So that comes in line with all health needs assessments to help us as commissioners understand the need within the area and whether there is enough dental practice in the area to meet that demand. And it's the gap that we work collaboratively with the public health local authority colleagues as part of that document to understand where those gaps are, and then that's where we commission services.
Have you got a plan to increase dental surgeries in certain part of the city at present time?
At the moment, there's no plans. In the paper, it does highlight practices that have terminated. So where practices have terminated, we do disperse that activity back in the area so it's not lost. And as my colleague Adam, who's the Chief Regional Dentist, we have some schemes as well to try and encourage uptake and try to ensure more patients get seen. But in terms of filling the gaps of what you're referring to, that's working with our colleagues in local authority to understand the gaps from that oral health needs assessment, and then we can have that strategy to actually plug those gaps and absolutely have more activity in those areas to meet that demand.
If I could also add, I totally appreciate... Sorry, I totally appreciate, obviously, populations do change and the size of the community may change within your ward, but obviously until we actually know what those changes are, we could end up putting, trying to encourage a dental practice to open or increase services of dental practices in totally the wrong place. So that's why we need to work with colleagues collaboratively to understand exactly where that need is, and working with yourselves to appreciate that before we can then put in a definitive plan to answer that or give a solution to that problem.
Can I just come in first, Catherine? I mean, thank you. I appreciate that, and we appreciate that there is a need for an informed plan. I was quite perturbed, though, on the map that you showed us, through the first one, where you have the number of dentist surgeries and then areas of deprivation. And just, I did see this in the report earlier. But I don't think it was coloured, so it wasn't quite so clear. But there's a whole swathe of area where it's very deep purple, very deprived, through Osmaston, Sinfin, down towards Allington in the city, where there are no dentists at all on your map, and that is really perturbing. And I appreciate that you're saying that people can travel there by car or by bus, but I think people do travel by car, even when sometimes when they are on a low income. But some of those areas, and obviously including parts of Normanton, but the ones I spotted on the side was Osmaston and Sinfin in particular. They are some of areas of extreme deprivation where people won't have cars, and it's also about that sense of the effort to do it too, with a sort of low motivation towards health. So I found it really disturbing that there aren't any dentists there. And in terms of the big, so you may want to come back on that, but also I can appreciate that at the moment what you can do is to some extent limited. But actually, we have been receiving endless reports as councillors, certainly the ones on the previous board, some of those who are on the board now, of people who just can't access NHS dentistry. So some of the dentists that you have on your map, I know those dentists because they're near to where I live, and neither of those two that are near to where I live, I mean, they're 2 minutes walk from my house, so that's nice for me. But what about the other people? And neither of those dentists now take NHS patients. One did, but one has recently dropped all of their NHS patients. So this is the big concern that we have. It's not just that there's a dentist practice there, and obviously in some areas there don't seem to be any dentist practices, particularly in the deprived areas. But there's also the fact that dentists are just deciding to drop their NHS pensions altogether, and many people cannot get access to an NHS dentist, and this is the overwhelming concern of our board, as expressed previously, and that's why we asked you to come this evening. So I don't know if you would like to respond to those concerns, please.
Yes, obviously will, and very concerned ourselves as well with the practices that are shifting the balance of the amount of NHS work that they are doing. This is driven in part by the dental contract, so obviously when we do get a reform of that will hopefully redress or address some of those issues there. But to reassure everyone, the access or the activity that is lost from these practices is redistributed within other practices in the area, and other practices have been keen to take up that activity at the moment. But totally understand where you are highlighting areas where there aren't practices. It is something that we need to lobby government about, to actually give more money so that we can actually try and provide for areas that don't have that provision at the moment.
I mean, I do appreciate that there is a need for a new health secretary. Some of us would argue a new government, but we're cross-party in this committee, and we need a fresh approach. We have just lost the health secretary, as you say, and we understand the problems are national and structural, really. But we also understand that your job is to do. To reflect accurately what is happening in Derby, and to do obviously what can be done to try and mitigate the fact that it is rather a two-tier system. But I mean, I have not been receiving reports of people who've been dropped and have just been moved to another dentist. What we have been receiving as counsellors is people writing to us quite desperate, saying they were dropped by the NHS dentist or they can't find one, and that they don't have any dentist. And sometimes that is actually also for their children. So people wrote to me last year and said that they had been dropped by their dentist as an NHS dentist. They were offered a private plan. That particular family decided that they could just about afford private insurance for their children, but then, you know, the reality is that they have been left without a dentist. So I kind of beg to differ on the presentation, that on that claim, that what you're saying there. I don't know if you have any response to that.
Yes, obviously the practices since the pandemic have been operating at a reduced capacity. So that has obviously limited the system in terms of the number of patients that are able to be seen. So whilst some practices do relinquish or rebase their contracts, then that activity has been redistributed. But in the time that it's been redistributed and the period of time you're talking about, the activity levels of those other practices were dramatically reduced because of the pandemic. So obviously, with time, as the activity levels are now expected to be 100%, it will hopefully start to pick up and people will start to be able to gain access.
So just before, Councillor Foggett, you wanted to come in. Sorry, just before I move on to Councillor Foggett, are we... I've had the good fortune of not having to visit the dentist much recently compared with 2 years ago, but are we now in a position where they are accepting they can see the normal amount of patients, or are they still operating under restricted conditions?
Well, Ram would like to come in there as well, but we are still operating under sort of slightly restricted systems, and it is very difficult to get back to 100% activity. But that is something that we're, as practitioners, having to learn to work with the virus and adapt to situations. But obviously at the moment there is a resurgence of the COVID virus, but obviously my colleague wants to come in as well and add to that comment.
Thank you. Yeah, I just want to add, so from a practice owner perspective, I'm here as the local dental network chair, but I also own a practice in north of Derbyshire. And just to reflect the challenges, even though from the first quarter of this financial year, practices, the target for NHS activity has been 95%, and from the 1st of July, it's been 100%. We've worked incredibly hard, and we have only managed to achieve about 80 to 85% level of activity. And that's not because we've prioritised private patients. We have very much tried our very best to achieve our NHS commitments. Yes, we are back to a normal infection control, or a near normal infection control procedure in terms of the amount of PPE that we have to wear and all the other restrictions. But our dentists and our nurses are still contracting COVID, and they are still having to isolate during that time. So it has been extremely challenging from that point of view. Even when we are back to 100% in terms of the amount of time it's taken us to see our patients, because we haven't got as many restrictions on the PPE, every patient that I see, or a lot of the patients that I see, are needing a lot more treatment than they used to. We are, as a general guideline, we're supposed to take x-rays every couple of years. So normally patients will have been in every 6 months or so. So it's every sort of fourth cycle that we need to take an x-ray. Whereas now, because they've not been in for a couple of years, every patient now requires an x-ray, which takes time to take the x-ray, develop it, interpret it and report it. And then we are finding that a lot of people are needing a lot more treatment, and that has a significant knock-on effect. So even servicing our regular patients who, had been attending our practice for many years, we are struggling to arrange their routine recalls at the moment as a 6-monthly or 12-monthly interval. So the challenges, unfortunately, are still there, even under sort of normal funding conditions.
Thank you. We do recognise the importance to protect dentists and dentist nurses and other staff from COVID, which we heard earlier is actually seeing higher numbers again. This is not a pandemic that's over, so we acknowledge that and thank them for the work they do. In a minute, I think is it Andrew Dale? I'm going to invite you to say a few words, Mr. Dale, but I'm just going to bring in, obviously, Councillor Froggatt now. Thank you.
Evening. Thank you for the report. Please excuse me back as we have to talk into the mic. As you know, we have a lack of GPs. Is the dentist industry going down that same route? Have we lost dentists through Brexit and COVID? Or, you know, have dentists just decided enough's enough and they're leaving the practices?
Yes, yes, and yes, basically. So the Brexit has had an issue. There has been a reduction in performers from that aspect. The pandemic has had an effect on the profession in that some practitioners have taken the opportunity to either reduce hours or fully retire. So there has been a very large change within the actual dentists within the NHS, and this has also been reflected with the nursing staff and other practice managers as well as. So the whole team has taken a hit within the last few years, and then trying to recruit people to those positions has been extremely difficult, and that's why we've tried to bring in the Golden Hello scheme as well for areas to try and encourage people back into those positions. So yes, it's an extremely challenging situation, and I think it is recognised by Health Education England that the numbers of dentists that are trained needs to be increased. But obviously this has such a long lead-in time, obviously with 5 years going through university before they can actually become into practice. So there are challenges to try and address the workforce issue that we have.
Yeah, thank you. I mean, we've had the same with the GP reports that we've had, where there's just an acknowledgement that actually we're just not training enough people. They're not coming through. There's a strategic problem here, and it does need to be fully acknowledged and recognised and dealt with, actually. But before I bring you in, Mr. Dale, I'll bring in Councillor Lonsdale.
I'm sorry. Okay, so I have a couple of questions as well. I would like you to tell me more about emergency dental care in the city. So someone hasn't got a dentist because they've fallen off the NHS list for whatever reason. What do they do? Is the emergency dental care, I believe the emergency dental care got closed down. So has that been reinstated? Is there a plan to reinstate it if it hasn't been reinstated?
Hi, yes. So yes, the provider contract did come to a natural end. We did re-procure. There are, I believe it's about 3 urgent dental, unscheduled dental care providers within the whole of Derbyshire. Access is through 111. So if it's during in-hours, then the access would be contacting, obviously, a general dental practice, and if they've got capacity, they'll be able to see you. There's also 111 who'll be able to obviously signpost you to a general dental practice. If it's during the out of hours, then if the patient is asked a series of questions from the call handler, and then they're then signposted to the practice, or a referral is sent to the practice, where the practice will then contact the patient. If it's the case where the end disposition, so if you call 111, and if they say you need to make contact with a dentist within 12 hours, and the patient says, I can't see a dentist in 12 hours, I do have an actual emergency, and obviously the pain is quite severe, that call is then passed on to a dental nurse's queue within 111. 111 then ask a few other series of questions to understand what the issue is, and they will then see which provider is operating in that area, and they will send an electronic nhs.net secure referral to that practice, and the practice will then call the patient, and then that's how they access urgent dental care. So the service hasn't ceased, it has been re-procured.
Okay, thank you. That's interesting. The other thing that concerns me is that the NHS website where you can go to find a dentist, an NHS dentist, is not necessarily being kept up to date. Has that been improved, or is that going to be improved soon?
Thank you for that. Yeah, I can respond to this. So this issue was raised a number of times, and Healthwatch have done a number of reports on this. So I've taken the lead to look into this issue, and I've actually had a number of meetings with the Nhs .uk team. They are revamping the website for dental practices profiles. There's been two issues. The first one is that it's not been updated. The second is that it's been quite confusing because there's an option for practices to choose that they are accepting patients on referral only. And both practices and patients have misunderstood the meaning of that, because that was meant to be for specialists' practices. But routine general practices have been using that option. So they have done a pilot of a revamped website, and they are taking that option completely out. So that's one big part of confusion that will hopefully be addressed. And they are making the system of updating the dental practices profiles much easier than it is at the moment, so that practices can automatically update it without having to log in and remember username and passwords and things like that. So hopefully from September there will be a significant change to the NHS website regarding dental practices. There is one issue that remains, is that there is no contractual obligation for dental practices to actually update their websites under the current terms of the contract. So we can only encourage practices to do that, and we do that through various networks, such as through the local dental network and through the local dental committees. But it may be that under the new contract that this will be enforced, which will hopefully help that problem too.
Thank you. I'm just going to ask Mr. Andrew Dale, can you explain which organisation you belong to, Mr. Dale?
I'm currently representing Derby City LDC today as a representative of that committee. I also
Sorry, which committee? Could
Derby City Local Dental Committee.
Committee, thank you.
We liaise with the regional area team and sit on meetings with them, so they're well known to us.
And would you like to make any? I think the contract is. Do you have any comments that you'd like to make about in general, or about the contract in particular?
Talk about the contract for hours, if you like. I mean, the dental contract is fundamentally broken, and that is really the issue. Dentists do not want to work in the NHS anymore, particularly younger dentists. Older dentists like me are choosing to sell and retire. And this has created a significant problem, and we're not being replaced. You cannot get dentists at the moment. You can't get nursing staff. The dental contract does not financially remunerate you for running a dental business. As Adam has already said, we're independent practitioners. We can choose who we want to work for. And I'm afraid that dentists are choosing to work outside the NHS. It's not viable anymore. And Adam said there are some negotiations about a new dental contract. That is only a sticking plaster over the problem. There's some talk about altering the bandings. It's very, very hush-hush at the moment. I know very little about what's going on. It's being kept secret from dentists. Dentists don't want to do it. So what's happening is they're just voting with their feet and walking away from the NHS. And, you know, if you look at the way the model works, if you were in business, you would do the same. And I'm sorry to say that is going to continue happening. And despite all the, the additional monies and things that are being thrown at us, it's not being utilised. It's not going anywhere useful, and there will be nobody left to run a decent NHS dental service. I'm sad to say that. If I was in the position I was 3 or 4 years ago now, I would probably be bankrupt, or I would have had to go private. And I was a dyed-in-the-wool NHS dentist for 35 years, and I couldn't make it work now. So I can understand why people aren't doing it. And it's sad for patients, that they can't access services, but it needs a properly funded, worked-out contract. And this has been going on, contract negotiations have been going on for the past 10 years. There's been pilots and all sorts of ideas tried, and they've all been chucked in the bin with practitioners thrown under a bus. So you can understand, if you look at the business model, you look at how dentistry works, why dentists like myself would walk away from it and not want to do it. Young dentists, I spoke to some young dentists at the weekend, and one of those was going to go to New Zealand because she didn't want to work in this country, in the system, and the other one was looking to do her foundation year and then go, and quickly as possible, go into private practice. And this is what's happening.
Yeah, I know a lot of Australia seems to be a preferred destination for a lot of doctors.
Going, yeah.
I wonder if you could give us, if it's possible, 2 or 3 points or a resume of what are some of the key problems with the contract then?
Where do you start? It doesn't. The fundamental thing is what is known as the unit of dental activity, and you have to do so many units of activity. Now, when 2006 started, that was relatively easy, but the goalposts have moved so much. The bureaucracy's got so much. The time you have to spend with patients, the amount of work you have to do with patients. All of that has changed. So to get that one UDA takes you twice as long or 3 times as long. So you're not going to hit your target at the end of the year. And the problem with that is if you don't hit your target or get to the 96%, you will get a breach notice. If you get 2 of those breach notices, Rose can come and take your contract off you, in theory. She'd probably renegotiate it, but you know, what is the incentive of working and working to try and hit a target you're not going to hit? You know, if you look in the report, it shows that the last period in COVID, about 60 to 80% of dentists hit target. They're going to get severe financial penalties. So why should I work in a system that's going to penalise me? I've spent that money. That's my profit that goes in my pocket. You know, I've got to make a living. I can't make a living because I'm having to pay clawback back. And that's what it's known as. The area team in years will probably get £5 or £6 million back in clawback. They do try to spend some of that, but historically it just goes down the pan into the wider NHS. And that's not going to change under this system. And we talked about integrated care services. Dentists don't have much representation on these bodies. We're hardly negotiating with them. The contract is national, so it's not going to change. But there will be, you know, Rose talks about commissioning. They're not going to want to commission it because the doctors will want the money first, and the doctors are afraid that secondary care is going to have all the money, and we will not have a voice. So that is really, I don't think, going to impact dentistry at all, with all the will in the world. And why should you get engaged in something like that you can't influence? You know, as local dental committees, we have very little sway in anything at all.
Thank you, Mr. Dale. I mean, I think I'm going to let you respond, and Rose. I think the reason we have pressed this issue so much is that in our own small way as a scrutiny committee and cross-party, we can raise these issues about where the priorities are in health or what's receiving a focus and what isn't receiving any focus. And so many people have contacted us as councillors about the problems they're having in accessing a dentist, but most notably an NHS dentist, and the problems they're having with emergency care. That's why we've asked you all here, and thank you all for coming, because it's our job to raise this. We obviously can't in this committee provide all the answers or any particular answers, but it is so important that this issue is raised. And people are made aware of it, because as you say, there could, in theory, hopefully there will be more funds coming through, given we've just had a 10% increase in national insurance. But I've been told by many people that a lot of that is earmarked for the NHS, not social care, and within the NHS is going, you know, there's assumptions that it will go towards the hospitals. So thank you. So so that's why we're here. So the fact that we're talking about this and making these points is in itself valuable at one level. I'll bring you in a moment in Councillor Khan, but so to be fair, I'm just going to let Rose and yourself respond. Thank you.
Thank you. So can I just address in terms of the 96%, and if you deliver less than that in 2 consecutive years, we come and take the contract off you. That's not necessarily true. What we do is work with providers to ensure there's that continuity of access for patients. And the reason why it should not be 100%, that should be the goal, but there is a 4% threshold. So if anything's delivered less than 96%, either 95.99%, it's an automatic clawback up to 100%. And with that clawback, we do our utmost to reinvest that back in dentistry. We do have a duty as well to protect the public funds, but at the end of the day, this is public money as well. So where we do have investments as well to try and increase access, we do have certain criteria as well that dental practice do have to meet before they're able to actually go ahead with that investment scheme. And the reason for that, again, is to avoid, say in quotation marks, paying them twice. So a practice has already obviously been remunerated for that activity. If they want to take on some additional access monies, they need to be able to reach a certain point. Otherwise, we're paying them twice to do this exact same thing. So we do have a duty to ensure that we are spending those public funds as effectively as we can. But in terms of access in the area, the pre-2006, it was a cost per item. So dentists, whatever they undertook, they got remunerated for it. So they did 2 fillings, got paid for 2 fillings. And then from 2006, it got moved to the banding. Yes, there's lots of issues and concerns regarding the current contract, which is why it's out of our control as a region. It sits in the national team, and as Adam says, there's hopefully a contract reform that's coming quite soon. We'll see what that brings, and then we can try and obviously work with that as regional commissioners to try and obviously plug those gaps, which takes me back to the original answer in terms of plugging those gaps. And as more money does come down, we then obviously work with our public health local authority colleagues to understand that oral health needs assessment so that we can commission those services in the right areas at the right place to obviously ensure access. But we are trying to do our utmost at the present moment during the difficult times.
Thank you. Did you want to say something as well before I bring in Councillor Khan?
Yeah, I'll just add just a quick note, and I completely agree with what Andy said in terms of it is a national issue primarily, but what we can do here is exert the pressure, and as you said, this is the sort of meeting where the more we discuss it, the more pressure there is, and hopefully this will get things moving. It is certainly challenging when we're moving on to the ICSs, and as Andy said, it is scary as dentists because we haven't got as much influence in there. However, my role as the LDN chair is to be the dental representative within the ICS for the area, and I have already had some engagement within the clinical and professional leadership group. So there are connections, and I would like to think it as an opportunity for improvement because we are all professional colleagues and we want to work together for the benefit of our patients. So yes, there is certainly a challenge because it is an unknown process, but we are fully engaged with it and we've got the wheels in motion to integrate within that system. But we need your help. We need pressure to be put on to make sure that our voice is heard and that our challenges are being addressed.
Thank you. Yes, well, I probably speak for all the councillors that are here tonight that we would all be strong advocates for NHS dentistry. But Councillor Khan.
Yeah, I think I'm going to go back on dental surgeries and GP services back in the 80s and 90s, because I feel the service is more better and better provided. Because maybe now it's financially not viable for dentists, but then obviously we as public, representing the public, we need to find a way. So maybe dentists or GPs got contracts, and maybe they started thinking as that as a business. So if they're thinking as that as a business, we have to make sure that we need to compete with them. May it be that we need to look out of England. Yeah? So train dentists or GPs and bring people from outside to provide that service, and maybe they might have, I don't know how that works, but I think that we need to be looking at that. So obviously, the public needs that National Health Service, that we are there to make sure that we pretend to provide that support for the public. So somehow we have to sort of find a way forward. Thank you.
Thank you. Did anybody want to respond to that?
No, international recruitment, I think Andy wants to come in as well. International recruitment is a very important part, and it is something that is being looked at again at the moment. Obviously, anybody that comes in from outside the UK, the regulations are changing, but we do have to ensure that those individuals are safe to practice with patients. So they do have to go through strict procedures to ensure all those types of things. But that is something that is currently being looked at by Health Education England to see if we can have any success in that aspect as well.
Thank you.
Yeah.
Mr. Dale, you wanted to...
Now, Adam's pretty much answered the question. There's also been the question about Brexit forcing dentists back, because a lot of European dentists came over here and they were admitted. There's quite a bit of talk about standardisation and acceptance of qualifications, but the truth is a lot of them went back because economically they were better off back home because things changed. Adam's right about the the Asian sort of side of things, people from India, that type of thing, historically came over here. That's been closed. There's a lot of issues with the General Dental Council and the overseas exam, the ORE, trying to get that sorted. And there are a number of British citizens who go to Europe to do qualifications, and as Adam says, some are very good and some have a lot to be desired, so it's getting that regulation and making it safe for the public. All these things have been looked at, but at the end of the day, again, you still have the issue that they don't want to work at the NHS.
Yeah, thank you. So we seem to be come to some fairly unanimous position that there is something of a crisis in NHS dentistry, both in terms of supply and access, and that many dentists no longer want to or feel able to work in the NHS. Hopefully there will be some improvement in access to dentistry given as we allegedly move away from high COVID levels. But nevertheless, we're not going to see a huge improvement necessarily because we don't have enough dentists coming through. So on that basis, unless there are no more questions, I'll put forward a recommendation. I think I'm referring to the right body here, given that we're now moving to an integrated care system. I would just say that the Adults and Health Scrutiny Board recommends that the integrated care system gives greater recognition to dentists and NHS dentistry and works towards improving NHS dentistry access and delivery as rapidly as possible. Yes, so can I second for that, please? Councillor Froggatt, those in favour? Unanimous. So we can send that recommendation through when we have representatives. We can talk to them again about NHS dentistry or dentistry. We can keep on highlighting dentistry. That's all we can do as a committee. We can be advocates on behalf of dentists as well as patients. If dentists are acknowledging that they can't deliver the service they want to deliver. So that's what we will do, and we will continue to do that. So thank you everyone for coming this evening. Before you leave, I wonder if you would mind staying for a moment, please, because I think it's desirable that they stay. Is it because Dr. Dewis is I'm now going to take her short report on fluoridation of water.
Apologies, there's just a few slides just summarising, but yeah, I'd greatly appreciate the expert voice in the room as well around this. Hello there, Dom. Fantastic, lovely. So, yeah, there was a question from the last meeting around water fluoridation, and so there's just a few slides really to explain the position, the benefits, the complexity, And when we get to the end, I don't think we have an answer, but at least you'll see the direction of travel anyway around this. So the first thing is that fluoride is found naturally in some drinking water. So some people will receive drinking water that already has substantial levels of fluoride in it, but it can also be added through the supply, through the water companies. And nationally, levels of 1 milligram per litre are recommended to improve oral health. And this is set there partly because WHO have advised that levels below 1.5 milligrams are safe if that's the water you're drinking throughout your lifetime. So that's recognised to be well within that safe level. And currently, around 1 in 10 people nationally have fluoride added to their water. But 70% of people in the country have concentrations of less than 0.2 milligrams per litre. So very low levels of fluoride. So next slide, please. And just a couple of maps, and these have come from the Office of Health Improvement and Disparities, who they publish regular reports assessing the impact of fluoridation of water. And this one's just from in the spring earlier this year. So this just shows you the areas of the country where there's a higher level of fluoride concentration. And you'll see, my geography is not brilliant, but you will see there's a concentration there around Birmingham, around Lincolnshire, up in the north of the country. There's a few little patches along what I believe is the M5 corridor, and then a little bit of darker area around Essex-Sussex border, which will be relevant in the next map. So if we just move to the next map, fantastic. So this then just summarises, these are the areas in blue which are fluoridating their water, and you'll see that fits very much from a north of England perspective with those areas where the higher concentrations are found. And then you'll see there's those red blotches around that M5 corridor, around the Sussex-Essex border, which is around the natural fluoridation. And that just relates to the geology of the area. Next slide, please. So just to think about the benefits and the challenges. So we know that fluoride in water significantly reduces oral health inequalities. We know that tooth decay, poor oral health, is strongly associated with deprivation. And we know that we've seen plenty of evidence from Birmingham around the impact. They've had fluoridated water since 1964, and a really significant impact on the children's teeth, particularly within Birmingham. Fluoride's also available through toothpaste and through fluoride varnishing, but for the majority of people and for children, fluoride varnishing is available when you see a dentist, and so that does compound the previous discussions. In the most 20% deprived areas nationally, 5-year-olds with fluoridated water have around a quarter less dental decay than those without. And children with fluoridated water are around half as likely to admit to hospital for tooth extraction. And tooth extraction is one of the highest reasons for children to be admitted for surgical procedures in hospital. So we can see there's a really significant positive impact from fluoridation, particularly for children in deprived areas. There have been concerns for many years around having a universal approach to this, in that we are providing additional fluoride to all of the population to particularly focus on our protection of part of the population. And some concerns within some groups in the population around the fact that this is added to my drinking water. It's very different if you choose to buy a food that's got added supplements within it, but with the drinking water there's much less choice around that. So that has created a lot of concerns in the past. There have been concerns about fluorosis, which is some white dappling on teeth when they're developing, but generally speaking, when that's been looked at, it's not been a significant concern or impact from those that have developed it. There's also been concerns about what impact this might have on other aspects of health, and whenever this is looked at, it's just very inconclusive. The evidence is just not there to provide, to say that there are these negative impacts. And what we do know is there's this tremendous positive impact from it. But it has remained an area of much debate and challenge, really, in this decision-making. Next slide, please, Tom. In addition to that, geography is complicated because we couldn't decide to fluoridate the water for Derby. It would be the area that's covered it spreads over into some of the district council areas of Derbyshire and also into Nottinghamshire as well. So it would require more than the city council agreeing that this is what we should take forward, which has created complications over the past. And you'll have seen from those maps before, the areas that are fluoridated don't really correspond with any boundaries that we would recognise. And just a note, no new schemes have been introduced for nearly 40 years, so I make that the kind of mid-1980s really, when the last time that this was actually happened. So the responsibility for commissioning fluoridation did sit with the NHS and was passed to us as upper tier local authorities in 2013. And that was part of when public health moved over as a public health responsibility. And I imagine there was a hope that within local authorities that progress would be made, but clearly it's been a real challenge nationally. So the Health and Care Bill, which has just been passed and has royal assent, passes to the Secretary of State the power to directly introduce, vary or terminate water fluoridation schemes. And I think this is a hope that there'll be a national approach to this so that we can actually get some movement. So that's a summary of where we are, and I'm very happy to take any questions on that or any comments from the experts in the room.
Thank you very much. Any questions, comments? I'll take you and then you, Mr. Dale.
Okay, sorry. Yes, I would just like to sort of add to my colleague's sort of description of things. Obviously, prevention is better than cure, and she's mentioned a lot of different things that we do try to do in practice with fluoride applications. But just to try and give a perspective, with 5-year-olds nationally, 38,000 children have to undergo general anaesthesia each year to have carious decayed teeth removed. Obviously, that isn't the situation any of us would like for one of our children to have to go through. So this is where, obviously, especially in deprived areas, the figures actually showed it's up to 63% improvements of reduction of those extractions that are required in those areas that are fluoridated. So it is really with quite a passion. I think if you speak to anybody in the dental profession, they would encourage water fluoridation where possible.
Thank you. Yeah, Mr. Dale.
Yeah, I'd like to reinforce that opinion that fluoridation is of great benefit, particularly with children. I worked in a fluoridated area when I first came here, and I rarely ever sent children for general anaesthetics. Look at the number of children that are going for general anaesthetics now. It's completely preventable. So, putting fluoride in water is the way to go. If you want to look at it financially, if you invest £1 in fluoridation, you will save £12 in dental treatment charges. That saved £11 could go towards treating your access problem, all these sort of things. Have you spoke to the British Fluoridation Society? Are you in contact with them? Are you in contact with the BFS? They provide a great source of information and advice about fluoride, so it's worth contacting them.
Okay, thank you.
They're fairly local. We have a representative in Leicester who I'm sure will be quite happy to come and speak to the council.
Right. Thank you very much. Yes, we'll look at that. Thank you for another meeting. Do any councillors want to comment? Councillor Lonsdale?
Are we actually in conversation with the other councils that would require to be talked to about maybe making this a thing to happen, since it's so heavily recommended by our colleagues?
So there have been tentative initial discussions in the past, but I think an acknowledgement of the amount of other work that we couldn't do if we were going to take this on and make it happen. And I think that's been the real challenge to it, because it would be a significant piece of work. But having said that, now that responsibility has moved to the Secretary of State, I mean, that absolute on that argument around you invest in fluoridation, the benefit nationally, they can realise that benefit. As a local authority, we would have been asked to invest in it and not realise the benefit ourselves. You can't work with that return on investment in the same way. Nationally, they'll be able to see that much more clearly, and I'm really hopeful that this move will help us to get some traction with it and some movement.
Thank you. Yes, I mean, this isn't something I know very much about, actually. I don't know about any other councillors, whether you have any views on this as such, but obviously the professionals strongly recommend it. So I guess I won't submit a formal recommendation, Robin, but obviously as you're here, we would recommend that you perhaps, you know, maybe this is something to bring back again, to look at again in this committee, and also for you to look at options for having discussions with other neighbouring councils, you know, initiating that discussion, seeing you know if it is worth moving it forward, because we do have a lot of deprived areas outside of the city as well as in the city. So I think it's something we'd probably, my point is I'd like to see it more on the agenda if that's possible.
And sorry.
Don't forget to put your...
At the back
Stay
there.
in dentistry.
Yeah, the key to this is lobbying the MPs, because if we can get the MPs on board and sort of get messages into their mailbags, then that will then force the Secretary of State to do something.
Okay, thank you. We'll reflect on that, perhaps take it back to our political groups and talk to our MPs.
Can I just say as well, we have attended other HOSCs as well, and we have been communicating the importance of fluoridation to obviously ensure other councillors help support us as well, and obviously in terms of the messaging and getting fluoridation into water. Okay, thank you. Well, what we'll do is we'll take on that recommendation to us to contact MPs, and we'll think about whether there's a place for discussing it again here in some context, where perhaps when we have some development maybe. I'll talk to Dr. Dewis about it outside the meeting and see how we could try and move this agenda along. Anyway, I'm conscious that time is moving on. We don't normally have meetings this long, actually. It's very rare. So I'd like to thank you all for coming and reporting to us on dentistry. It's very interesting. You've heard from us how difficult it is for people to access dentistry, and we've heard from you that you're struggling to recruit, and there are lots of problems. So hopefully we will see some improvement, and I won't make any further comment on the national situation. Thank you. And thank you, Dr. Dewis.
Thank you.
Very quickly then, we will move on to our next item. Thank you for waiting very patiently. It's Sean Thornton from Derby NHS and Derbyshire Clinical Commissioning Group, and he's going to talk to us about the People and Community Strategic Approach to Engagement.
Thank you. Good evening. Yes, so Sean Thornton, Deputy Director of Communication Engagement with what was the Clinical Commissioning Group, now the Integrated Care Board as of last Friday. I'll try and be very brief. Just to say that the document submitted, whilst it was built in PowerPoint, I'm not going to take you through 48 slides because that'll take a long time. So I'm just going to pull out maybe sort of 8 or 9 points from some of the slides, and hopefully Dominic can follow my instructions to go to the right ones. Just to say that this was written as part of the submission process for the Integrated Care Board for our establishment. So it's a work in progress, and I'm bringing it to the committee and the board just for your information at this stage, hopefully to give you some assurance that the approach we're taking is thorough, working increasingly in partnership with our integrated care partners, including the local authority and the voluntary sector in Derby. It will be used to then be deployed to support the development of our integrated care strategy that we're legally obliged to develop during the course of this year. And obviously we'll come back at points in time with specific details of what that engagement approach looks like. This is the strategic approach, so just to put that in the context. If we just go to the second slide, that's it. So I've kind of covered large parts of that slide already. I just wanted to say that it is an evolving document. So it's been submitted to NHS England as part of that assurance process, but I didn't want you to think you were seeing it after the fact that it's all done. This is an evolving piece of work which will evolve over the course of the next 2 or 3 years. I would have thought, actually, not even the next 2 or 3 months. If I could just go to what is in the pack as page 4. The next one, sorry, the next one. That's it. So I just wanted to pick out, again, these aren't intended to be slides, so I'm taking the broad document as being read, but just wanted to point out there about our ambition around this strategic approach, and actually placing citizens at the heart of decision making within the integrated care system. There are differences, obviously, between the way the NHS is engaged with local people and the way the local authorities engage with local people. But I think I just wanted to flag that we're very keen to learn from the things we've experienced through the pandemic. We work very closely with local authority colleagues on the sort of health inequalities approach to the vaccination programme, for example. And I think it's very clear that we've learned that whilst the NHS doesn't necessarily have detailed relationships with community groups and people who are suffering from health inequalities, the local authorities do, and we're not seeking to replicate those at all, and to work in partnership with what already exists. Dominic, if I could just go to the next page. This slide just sets out some of the national guidance around working with people and communities that came out to support the establishment of integrated care boards and integrated care partnerships. It set out these 10 priorities and principles. And just to say, we had a pre-agreed communication engagement strategy for Joined Up Care Derbyshire, and pleased to say that our principles within that document were easy to map against these national principles. Just to pull out that, again, the first principle there is putting the voices of people and communities at the centre of decision making. We are very keen to develop a continuous engagement approach with communities. So we're not in the NHS. I think we've probably talked to communities at the time of a significant change, whereas actually we want to have ongoing conversations. So when the change comes, that's actually been informed and influenced by those conversations, and formal consultations, while they're still very important and legally bound, they're fully informed, and they're just a kind of part of the ongoing process of conversations with local communities. Principle 5 there, just to flag there, we are increasingly working with Healthwatch, Derby and the voluntary community and social enterprise sector as key partners. I've got a meeting with those people and our local authority colleagues tomorrow to talk about how can we use our kind of collective assets to develop the engagement approach around the integrated care strategy. We have to submit that strategy later this year, but clearly the engagement in that starts soon, and obviously, and also working with Dr. Jewis and other people to make sure that we are engaging appropriately in the kind of health inequalities priorities of our system. I won't go into the detail of the rest of those priorities, but obviously you can read them in the pack. If I could just go to page 10, Dominic, sorry. I just wanted to flag here that we've got, you can see within the pack, we've got a range of frameworks, as we've called them, and there's a kind of governance framework and insight framework. I just wanted to flag this, what we've got called the Public Partnership Committee. So that will be within initially the Integrated Care Board. That will be the governance mechanism that reports to the board, which will check that we are meeting our legal duties around engagement and involvement as set out in the Health and Care Act. They've not been amended massively as a result of the change from CCGs to ICBs. But there is that committee that will officially report into the Integrated Care Board to assure the board that we are meeting our legal duties around engagement and involvement. And I think it's important to stress there are legal duties we've got around this, but actually we want to go beyond that because we think there's a moral duty to engage and involve our population, and actually the evidence shows that you get better outcomes as a result of doing that. So I just wanted to flag that up. That partnership will include representation from Healthwatch, and we are seeking to include representation from local authorities as well on that. I'll skip a couple of the things I was going to talk about. If I could just go to page 19, Dominic, sorry. I'm following you myself on my screen. just a flag on this. We've got. I hope colleagues are aware that we've got what are known as place partnerships now in the county and the city. So there's a Derby Place Partnership, which is chaired by Pervez, who I'm sure you all know very well, and then there's a County Place Partnership. And just to flag that we are very clear that those local community relationships and the assets within those communities are where we will get the richest information and dialogue with people. So we are working with those place partnerships. It's a very early days, but just to test out how that engagement approach can work and how we can seek to capture the conversations that are already taking place through workers on the ground, such as the local area coordinators, and that linked into the intelligence we get from NHS services and the intelligence we get from our actual sort of more formal engagement processes. So I just wanted to flag that's a work in progress, but we think that is kind of a fundamental part of how our engagement approach will work across the system. Only a few more. Just if you go to page 23, Dominic, thank you. I just wanted to flag up here that there's more detail on all of these things within the document. Sorry, page 24. Sorry, Dominic, I think I've gone to the wrong page. Oh no, I was right first time. Page 23. Sorry. That's it. Thank you. So just to flag that we've got quite a deep and detailed sort of infrastructure, if you like, around our engagement approach, which we've actually spent some time during the pandemic developing. So we have now got a formal citizens panel, which is the membership of which consists of local people across Derby and Derbyshire. We've developed what we call an online engagement platform, which gives us opportunities to have continuous online conversations with local people. And we've got our Derbyshire Dialogue programme, which we've started during the pandemic. It's a virtual forum where we talk to local people about things like cancer and end-of-life services, mental health services. That's been quite successful so far. These are quite virtual-driven processes, and we're now much more able, increasingly able, as we've heard in other conversations, to relax our restrictions on going out and talking to people in their communities. And as we enter the next couple of months around the development of the integrated care strategy, we very much will be complementing these processes with face-to-face engagement with people where that's appropriate and desired. I just wanted to flag that. I've got three more just to point out. Page 33, Dominic, please. Sorry. Yes, so sorry. This was just to emphasise the point that the slides beyond this talk about the detail of the partnerships, but just to flag that we do have growing relationships with existing networks and partnerships across the city. And as I've said before, we're not seeking to recreate or replicate those. We're very keen to work with the partnerships and networks that already exist, and that's very quickly growing as we develop the approach, and with lots of strong relationships now with our partners in public health and the voluntary sector in Derby. Just two more to go. Sorry, if you go to page 45, Dominic. Sorry. So just I'm not going to go through these at all, but just we have tried to set out what we think our strengths are in this engagement approach. I think we have had some of these approaches. Our insight approach, for example, and the way we've developed a system insight group and library has been pulled out as good practice by some of the national guidance on this. But on the following page, on page 46, we are very clear there are areas for development in this, especially how do we effectively pool our resources and coordinate resource and expertise across the different boundaries of the organisations to make sure we're all understanding and contributing to the effective partnership. I think there's a kind of a sense of, whilst we're very clear that we need to have tailored and bespoke approaches to different community groups, we're very clear that there's a sense of there's one population, so we don't want to be going and talking to individual groups multiple times as multiple partners. So I'm going to stop there. As I've said at the start, just this is a framework. It's not talking about what the priorities are going to be and what we're going to go and talk to people about. But we will deploy this framework during the course of the rest of this year as we develop the integrated care strategy, and obviously come back to board with more detailed plans around what that engagement looks like when the time's right. Perhaps I think that your next meeting, it might be a good time to do that, and I'll stop there.
Thank you very much, and thank you, Mert, for being brief, as we're kind of, we're running, well, not over time actually, but it's long enough, so thank you very much. Yeah, that was very interesting actually. Does anybody have any comments? Councillor Khan?
You know, it mentions voluntary groups, mention health inequality. Would you yourselves be leading this, or somebody else going to be leading this?
I think the partnership, so the integrated care partnership, will be leading this. So Dr. Dewis actually is leading the work on our health and equality strategy. We can perhaps provide a bit of a briefing on the various elements to this. We have to develop an integrated care strategy, which then informs our integrated, which is the health and social care partnership. We then have to respond to that with an integrated care board strategy, which is the NHS's response to that. Part of that then is a health and equality strategy. So Dr. Jewis is leading that work, actually leading it on behalf of the NHS, despite the fact she's a director of public health. I think that's quite a significant point, that she is the systems lead on this. And then that will outline where we think our health inequalities lie and what we think we need to do to tackle that. That work is developing. And the integrated care partnership that met in shadow form a week last Thursday heard an initial report from Dr. Dewis on what we thought those priorities start to look like around smoking prevention, alcohol reduction, those sorts of things, as well as some of the community interventions.
You also touched on area coordinators and their social subscribers, because I work in a voluntary sector also. So I think they work on the ground roots. So I think the feedback from them coming into this should be very useful. So, and also for us to know that at a ground root level, what's actually the people and the community, the issues are that can go into this strategy.
Absolutely. At the meeting I mentioned that we're having tomorrow with colleagues, with Kim from Community Action Derby and colleagues from the local authority, I think one of the key principles is that we probably know a lot of the insight that is there to be known through these different elements. So the first step is to capture that, not go out and ask for it again, because I think people get fatigued at being asked multiple times for the same information. So absolutely, we need to understand how do we capture the feedback we're getting through those different services and build from there.
Some of this, look at it, so it reminds me of similar stuff happened a couple of years back. Sorry, yeah. So and actually making a big difference within. And I'm more into within the community. So I think, okay, I know Kim quite well. She works for Community Action, and she's the chief executive for Community Action. So she works with a lot of groups. But it's the difference that makes up the ground root that need to be added into that, and how that can be tackled.
Absolutely, and the principles hopefully outline that kind of approach, that this is about listening to the needs of local people and putting things in place that help them. So it's all early days work in progress, but I completely agree with what you're saying.
Us councillors also, I think we also get views from our residents, our constituents, and I think all that come into that.
Absolutely, I completely agree.
Okay, thank you. Well, perhaps you said you would come back at the next meeting, and I think what we'll do then, if you're coming back at the next meeting, is we'll put you towards the top of the agenda so that we're not all jaded and we can all engage with it a bit more, purposefully, if that's right. So thank you for coming and giving us the draft plan. I think it sounds very positive. I know Councillor Khan recently organised a a conference, didn't you, on health inequalities, and so it is, which I also attended actually. But so it is something we care a lot about, and but also the engagement around that with the community, which was the focus of this conference. So I think I'm actually confident that actually we've all got more to say on this. I'm just very mindful that it's 8:25, and I think that we, you know, so please come back next time.
Okay. No, thank you. I will do. Thank you.
Thank you. So actually that just leads very neatly on, actually, very quickly then, to our work programme and topic review, because this is a Radio 2 link here, I think, because I was going to suggest, so we need to look at areas we might look at. So one of the areas I was going to suggest that we focus on having a report, probably mainly, talking with Robin, is the health inequality issue, because the public health report that we were sent following the impact of COVID was the statistics in that are quite shocking, about not only the existing health inequalities, but the way they've been absolutely exacerbated by COVID. So that's one area I was going to suggest. Another is A&E waiting times. And then we also carrying over services for people with learning difficulties. And do we have any others that we'd like to look at? Councillor Foggett.
Can we add discharge to the A&E, please, because they are still struggling. They're still struggling to get people out.
Yeah, I mean, I know they are caused, the waiting times are, we know, yeah, so but perhaps that's a bit too narrow a description then, yeah, because the waiting times are caused by the problems with discharge. So I can't think at the moment how to rephrase that as a term, but we'll ask them to look at the kind of throughput through the hospital.
And are we going to be bringing back Clive back, maybe end of the year or something, from GP services or something?
Yes, we can do more. Yeah, we can do. Yeah, we will do. Yeah. Councillor Lonsdale.
So I was hoping to talk a bit more about mental health issues in the city, and possibly again the disparity between rich and poor and that. Is this my opportunity to? Yeah. Okay. We've had a conversation previous. So we were talking about possibly for our topic review, talking about obesity and what the city's doing for to help people to not end up in a position where they are obese, and when they have ended up in that position, what we are actually doing as a city to support them in reducing their weight and living a healthier lifestyle. So that was, and again that's a huge. I mean, it's such a wide topic, but we were talking again about health inequalities and about the difference between, you know, that it's more about, as food poverty actually results in more obesity, which is not great, and all that sort of thing. So how do people feel about that as a topic? What would you, yeah.
Any views on that? You happy with that? Yeah, we can give it a different angle. You know, we can. Yeah, go on.
I mean, it covers a lot of angles. It's not just the health. It's more takeaways. You know, it's planning, giving permission for takeaways, putting them outside schools. You know what I mean? So it is a very, very large area to cover. It's not just somebody eating something. It's the whole social scale on it.
There's also the fact that more and more food is getting more and more fat and sugar in it. Food is becoming more addictive because of that, which makes it hard. And also, when it comes to the cheapest food, that's what it's full of. It's not full of nutritious, good, healthy things. It's full of basically rubbish. So I think that's a huge problem that we're facing as a society.
You know, Chair, like I mentioned Kim, and she works in the voluntary sector. So can we, are this board able to invite her, sort of present some sort of a report on voluntary sector or how partnership is working?
In relation to health?
Health, yeah.
Yes, if she covers that area, definitely. You know, the sort of voluntary sector impact on a contribution to health, or okay, Kim Harper. Yep, that's a report. Are you noting these, Dominic? Yeah. Okay, so that's a list for now. We can add to it as we go along. Does anybody else want to add anything more for now? Okay, thank you. And we are in agreement for the obesity, but it will need honing, it will need scoping. Yeah. Okay, brilliant, thank you. So the very last thing then, we do have a report that was actually from Sean, but he's left, but I don't think he was only for information anyway, which is on primary care enhanced excess report. So I briefly looked at that, and I think it actually is very interesting, particularly should be for you, Jangir, because it is about access to primary care, which we've talked about a lot. So I think for now, can I just recommend, as it's Harper State, we note that, but we go away and read it in more detail, and we come back and think about maybe inviting Sean. Well, he's coming to the next meeting anyway, so it might be that we can talk to him about this in more detail, I think, because I think it may actually, we may want to make particular suggestions to him about it. So shall we do that? Yeah. Okay, well that, I think, is the end of the meeting. Thanks very much, everyone. Thank you.